So my name is Tony Larder. I'm from Michigan State, fourth-year student, planning to go into neurosurgery, and my presentation is going to be on primary CNS lymphoma. So the reason why we are kind of talking about this, we had a patient, initials were ER, and she came in with altered mental status, 68-year-old female, came in with altered mental status for the past several weeks, and her family kind of brought her in. She had this this lesion on the left is T1, middle is T1 with contrast, and then the right is flare. So she had this left frontotemporal mass that was enhancing, and it was contrast enhancing, and there was a lot of edema associated with it, with mental status and personality changes. She had a little bit of aphasia as well. So then we gave her steroids for her swelling. This is pre-steroids on the left, and I think it was 3 days after steroids on the right. So the mass itself and the enhancement went down. So that's what got us talking about CNS lymphoma. So that's what I'm going to be presenting today. Just an outline of what I'll be talking about for time's sake. So the definition of CNS lymphoma, it's extranodal non-Hodgkin's lymphoma. It's almost always a large B-cell lymphoma, and it can be primary CNS lymphoma if it's involving the brain, meninges, eyes, or spinal cord, and that's kind of the order of how common each one is. So there's 4 cases per 1 million people per year. 4% of newly diagnosed primary CNS tumors are CNS lymphomas, and even smaller amount of malignant lymphomas are primary CNS lymphomas. Slightly more common in men than women. 52-year-old median age of diagnosis for overall, and then for specifically immunocompromised people, 34 years old is the median age diagnosis. And incidence continues to rise even in the immunocompetent people. And the hypothesis for that is just that older people's immune systems aren't working as well. As the population ages, we'll see more of it. So risk factors, immunodeficiency is number 1. It is an AIDS-defining malignancy. It's usually seen with a CD4 count of less than 50. Also with iatrogenic immune suppression from transplant patients, and then a number of congenital immunodeficiencies can also predispose them to it. Epstein-Barr virus is associated with lymphoma for reasons I'll talk about in a minute, but also most autoimmune diseases have some sort of association with it. This is just kind of the list of the most common associations. So the pathogenesis in immunocompromised people, basically 100% of all primary CNS lymphoma is related to Epstein-Barr virus and latent infection. So when they become immunocompromised, they have diminished T cell function. The B cell lines that harbor the latent Epstein-Barr virus are able to proliferate unchecked. That's likely due to an oncogene related to the Epstein-Barr virus. And then another hypothesis for immunocompetent people would be malignant transformation of lymphocytes, either normally tracking ones or lymphocytes that have specific tropism for the CNS, specifically CD44 and CD18 positive lymphocytes. Those are just some surface markers that have high tropism for the CNS. So there's also increased expression of interleukin-4 in primary CNS lymphoma. It's a B-cell growth factor that's not usually present in the central nervous system, and that's what's responsible for causing the angiotropic growth that you see in B cells in primary CNS lymphoma. So the most common presenting symptoms are nonspecific, just like Our Lady. The mental status changes, personality changes, and more non-focal symptoms: headache, nausea, vomiting, generalized seizures. And then you could also, depending on where the mass is, you could have any of the focal symptoms as well. Patients may also present, it's pretty rare, but they may present with neurolymphomatosis, which is essentially the lymphoma invading a nerve. And that usually presents with both motor and sensory dysfunction. And then the presenting signs are would be the signs themselves are usually focal, even though the symptoms usually aren't. So heavy motor sensory deficits, aphasia, and visual field deficits, and then non-focal symptoms, signs like papilledema, encephalopathy, and dementia. So workup for suspected primary CNS lymphoma, the MRI with and without contrast, CSF analysis. Obviously, as long as there's no mass effect or suspected increased intracranial pressure. You want a slit lamp exam of both eyes, mainly because it's easier and safer to get a biopsy from the eyes than it is from the brain. Testicular ultrasound, testicular lymphoma commonly metastasizes to the central nervous system. And then brain biopsy is needed for a definitive diagnosis if you can't get an ocular, if there's no ocular lesions, and if CSF samples are inconclusive, which is 90% of the time. You should also get a CT chest and abdomen to check for other occult lymphoma, and then the bottom just says good lymph node physical exam. So on CT, primary CNS lymphoma, an immunocompetent person shows is isodense or hyperdense, usually homogeneous in the central gray or corpus callosum most commonly. It's sometimes called a pseudomeningioma pattern because it's in contact with the ependema or meningeal surfaces and has dense enhancement. The difference being that there's no calcification. You don't see calcifications in primary CNS lymphoma. So here's an example of a CT of a primary CNS lymphoma right here, kind of at the caudate of the right lateral ventricle. An immunocompromised patient, the CT will usually be multifocal, ring enhancing lesions with a necrotic center. And this is shown up kind of dark, but this is what that would look like. So on MRI, in immunocompetent people, the MRI, the lesions are usually solitary again, almost always periventricular, near the corpus callosum and basal ganglia, and followed by frontal, parietal, temporal, and occipital lobes. Most are sharply circumscribed, and most also have mass effect and edema. And then also on MRI, they'll be bright on DWI with restricted diffusion, and iso-intense to hypo-intense on ADC map. And then they're also called the ghost cell tumors because on MRI, you will get rapid partial to complete resolution after steroids. So here's, it's very hard to see, I can tell, but we have a T1 post-contrast, and then T2 and DWI. Yeah, it's showing up okay here. So CSF analysis you want to do before biopsy just to be able to save them in brain surgery, but you want to include cell counts, protein and glucose, cytology, flow cytometry, and then IG heavy chain rearrangement studies by PCR. And the cytology is really what's going to make a definitive diagnosis if it is primary CNS lymphoma. So usually the CSF isn't positive for lymphoma. It's only 10% of the time. Usually just shows a lymphocytic predominant pleocytosis and a non-specific elevated protein. But if there are malignant lymphocytes in the CNS, that's all you need to diagnose primary CNS lymphoma. So this is just, you can also do a immunophenotype analysis on CSF to kind of differentiate between B and T cell lymphoma, reactive lymphocytes versus malignant lymphocytes, and and versus small medulloblastoma cells. Something Dr. Hariri pointed out to me is that there's been a couple of studies that have shown that there's a high CSF interleukin-10 level in most primary CNS lymphoma cases. It's not, the recommendations don't really mention anything about ordering an IL-10 level in these cases, but these are pretty convincing numbers in both these studies. This one, I believe, had 25 or 27 subject, and this one had 100. It was, in both studies, it was the interleukin-10, even just over 3, was 100% specific for primary CNS lymphoma. And in all these cases, it was primary CNS lymphoma versus another type of brain tumor. Then you also want to do the slit lamp exam, like I said, and the testicular ultrasound. So stereotactic needle biopsy is a procedure of choice in CNS lymphoma. That is, if you don't have a diagnosis yet. Unfortunately, the tumors are usually deep. You don't want to resect it because there is a theoretical risk of seeding the leptomeninges. And patients should be off of steroids prior to biopsy because that can decrease the yield. The pathologic features are the cells, the malignant cells are surrounding the vasculature. They look just like systemic lymphoma cells, so they're just basically large and mature lymphocytes with big nuclei, big nucleoli, very basophilic centers. They're usually positive for these 3 markers, which are B-cell lymphoma markers, or the BCLs, and the MUM1 is actually a multiple myeloma marker that's also usually common in primary CNS lymphoma. And they're always negative for CD138. There's the absence of desmosomes, and there's this typical hooping pattern that you can also see, which is when you do a reticulin stain, and you can see the silver staining material between each of the cells. Again, resection or debulking does not improve outcomes and may lower survival. Whole brain radiation works very well to kill the cells of primary CNS lymphoma, but there's been a lot of morbidity associated with it, so it's now considered an alternative to second-line chemo, or in cases where it's just for palliative measure. The mainstay of treatment is methotrexate-based chemotherapy. It's the single most effective agent in primary CNS lymphoma. You need to give it in high doses to penetrate the CNS. It's usually not given intraventricular anymore. It's usually just given IV. Leucovorin is something you can give with it too to prevent systemic toxicity and keep the blood counts up. The 2 most common other agents used in combination with methotrexate are cytarabine and temozolomide. And then there's a few other things you can give. Obviously, the rituximab is a pretty common one as well. Anti-CD20 monoclonal antibody will attack the B cells, and then steroids to decrease the edema associated with it as well. I found some studies talking about gamma knife. Again, gamma knife isn't something that's talked about in the guidelines that are published, but the studies that I found showed a good response to stereotactic radiosurgery. So I thought I'd just add that in here. Increases survival and improves symptoms. So this is just the kind of flow chart for treatment. I won't go through it all, but it's basically just methotrexate-based chemo. And then if that doesn't work, you can try second-line chemo or radiation. And then anything over here, this is just for the older patients who'd like to be treated, have adequate renal function, still stick with methotrexate with another agent. In HIV, high-dose methotrexate again, in combination with highly active antiretroviral therapy. Again, you usually don't need whole brain radiation. So the prognosis, with no treatment, primary CNS lymphoma is rapidly fatal in about 1.5 months. With chemo or with chemo with radiation, 44 months is the average lifespan after diagnosis. And 15 to 20% of people actually get long-term survival with methotrexate-based chemo. These are just things that will make your prognosis worse: poor baseline performance, old age, high LDH, elevated CSF protein, and then the deeper it is, and then the presence of the B-cell lymphoma 2 marker. So this is just a summary. This is the last slide. Just some pearls, the main points to remember. Any questions?